Dear colleagues, welcome on PRF education. To do PRF, we need to collect the blood from the patient. It's a mandatory step. This procedure is often considered as a difficult obstacle by dentists. My goal today is to teach you a simple technique. And when the technique is easy and reproducible, its learning is simplified. I made this course to deliver you a clear and didactic education. Enjoy! The course will follow this plan. On the first chapter, we will see the anatomy, the necessary equipment, and the timing of the phlebotomy. On chapter 2, we will learn the technique step by step. We will see how to handle the tricky situation you can encounter during phlebotomy, and then we will see the contraindication. On the final chapter, we will analyze some of our trainees' first phlebotomy. Let's talk about the anatomy. Phlebotomy is performed in a vein. And why a vein and not an artery? Here are the features. First, the veins are more superficial, more visible. Their walls are thin and thus easily prickable. And finally, the vein flow is quite slow. In case of an injury, the bleeding will be limited. The preferential site for the venipuncture is the elbow crease, the antecubital part of the arm. There, the veins are thick, thus the access is easy for us, and there is a lower risk of collapse. Moreover, the innervation is reduced. The procedure is more comfortable for our patient. Let's analyze the patient, and on the two arms we have an internal side and an external side. Let's focus, for example, on the left arm. We have two major veins in the elbow crease. The first one is the cephalic vein, which is external. The internal vein is the basilic vein. To remember, the basilic vein is facing the base of the lung. It is internal. When the two veins are visible, which one to prioritize? You have to know that the cephalic vein is usually thicker and more stable, meaning it rolls less compared to the basilic vein. Let's go a bit more into details. The basilic vein and cephalic vein will become later the ulnar superficial and the radial superficial vein. In the middle, the median basilic and median cephalic join each other to become the median vein of the arm. And if we pay attention, we see that actually in the elbow crease, the veins are forming an M. We call it the M design. We can retrieve this drawing on anatomical charts. The M design is very useful because, like in this case, when you don't see the vein, you will know where to find them because the veins are inside this M design. Of course, it's theoretical. Indeed, there are 4 branches, but they are not all mandatory. Sometimes you will have patients with only 1 branch in the middle. Sometimes you will have 2 branches. You can also have 3, and even the 4 branches of the M. They can even draw a perfect M. But remember, at the end, you only need 1 branch. If you have 4, you will have the choice, but you will only use 1 for the venipuncture. Most frequently, you will note the 2 median branches of the M forming a V like in those pictures. We often get the question, can we draw the patient blood on the back of the hand? Please avoid. Yes, it's tempting because the vein can be quite thick, but on the hand, the vein walls are thin, and when you connect the tube, the vacuum can provoke their collapse. Moreover, the innervation on the end is important, and the puncture will be less comfortable for the patient. Let's move on to the vein search. You have to know that the 2 arms of our patients are different. The anatomy is always more favorable in one arm than on the other. So, if you see difficulties or an arm where you don't see the vein, systematically go to look on the other arm. It could be easier. You can also ask the patient for some indication. You can ask them, when you go to the lab, which arm are they taking? They can give you indications. There are 3 types of detection, and the first one is obvious, it's the visual detection. It is actually possible in 70 to 80% of the cases. Indeed, in those types of arm, you can clearly see the veins. But my friend, be careful of traps. Sometimes you can see bluish line, but they are actually venules. Really narrow, sometimes thinner than your needle, and that cannot be used for the venipuncture. The only efficient detection is the tactile detection, the palpation. And we need to systematically do palpation, either the vein is visible or not. And this is how we do it. We palpate the patient's skin in the elbow crease to look for the vein. A personal tip. When the case is quite difficult, don't hesitate to close your eyes during palpation to avoid being influenced by what you see and concentrate on what you feel. I told you, the palpation is systematic. Either you see the veins or not. We use the index, which is the finger with the best tactile sensitivity. And with this index, we will look for the very particular feeling of the vein wall. It is an elastic, bouncy sensation. We must palpate the vein. It will give us a lot of information. You will have information on the anatomy of the area, on the volume, which can help you choose between 2 veins. You will know the direction of the veins, their depth, their mobility. But for me, the most interesting thing with palpation is that it will train yourself for the difficult cases. Indeed, after palpating 10, 50 or 100 veins, your brain will automatically recognize the feeling, the sensation of the vein wall. And when you encounter a difficult case where you don't see the vein, when you're palpating, the smallest elastic bouncy feel your finger will touch, your brain will recognize it, and you will know that yes, there is a vein here. We can get help for the detection. The first one is to apply alcohol on the patient's skin and to tap on it. Tapping the skin will heat it, and the use of alcohol will potentiate this heating. It also disinfects the area. See the difference before and after putting alcohol and tapping the skin. When you tap the skin, you will increase the vein volume and make them easier to find and to prick. Another help is the arm position. See here, when the arm is stretched, we can barely palpate the arm. But if you fold a bit the patient's arm, you can palpate much deeper veins. You could also ask the patient to pump with the fist to increase the vein volume. This action can also be helpful when your tubes fill slowly and you want to increase the filling speed. Should we wear gloves? Remember, I told you the one and only efficient tool for the vein search and the venipuncture is the palpation. If you wear latex or nitrile, it can disturb the palpation and you will miss some feeling, some information. If you really want to put gloves, you should wear them either after the palpation or on the other end just to hold the tubes. And finally, we can use light to detect the vein. We can use this small device called the vein light, which can help us to make the veins visible by transient illumination. Indeed, see with the red lights how the veins appear like a black tube. With the vein light, you increase the contrast of the vein with the skin, and the veins appear like a black tube. You can actually see it. Another tip: always check the patient vein during the pre-op appointment. It will allow you to diagnose the difficult cases in advance. Let me explain myself. If the case is easy, you will gain time for the surgery day and you will feel relaxed because you will know that, okay, this patient is going to be easy to do venipuncture on. If the case is quite difficult, take time to look for the best vein and maybe note it in the patient file for the day of the surgery. If the case is really difficult, maybe call a nurse to help you for the day. Those cases are rare, maybe 5%, but it's better not to spend too much time on the vein search and feel stressed about it. Call a nurse to help you. Let's move on to the necessary equipment for the phlebotomy. We have the tourniquet, the alcohol, the bandage, the vein lighting option, the blood collectors, and the tubes. First, the tourniquet. hold it through the central part with your right hand. Then take the tip with your left hand to buckle it through the arrows. Then you can pull to tight. See? Connect the arrows together and pull to tight the tourniquets. The alcohol, I told you, we need systematically alcohol to disinfect the area and heat the skin, dilate the vein, and make them easier to look and to prick. I advise you to use this kind of little spray bottle for the alcohol. It's very useful to use the right amount of alcohol without it to flow all over the patient arm. Now the adhesive bandage. As a classical bandage, the first interest is to protect the puncture point with its central gauze. But here also with the lateral adhesive stripes, you will immobilize the needle and thus secure the venous access. This way, the needle is fixed and cannot move anymore. The bandage has to be prepared and set on the dominant hand. On the left hand if you're left-handed, on the right if you're right-handed. See how the bandage is always ready to use. This way, as the second I'm inside the vein, I can fix my needle and breathe. Nothing can move anymore. The fixing is mandatory. See here how the needle is moving and how you may risk to prick the vein and fail the phlebotomy. We must immobilize our needles. Speaking of needle, the blood collector. It is inside an individual package and it has to be opened only through the notch here. The needle is called a butterfly needle because it has wings, and the needle is held always by one of the wings. Make sure that the plastic cylinder doesn't cover up the needle. If so, pull the moving cylinder towards the bottom to free the needle. The wings of the butterfly have two different faces. The first one is smooth and the other one is rough. We can see little studs on the surface. And this needle is held by the rough surface. It's like an anti-slippery surface. This way, you have the bevel facing you for the phlebotomy. And now the tubes. To do PRF, we need specific tubes, which have no anticoagulants and no additive. They are 100% safe. They are sterile, inside and outside, and of course, they are single-use. My friend, I'm drawing your attention on these kinds of plastic tubes which have silica coating inside. Those tubes are made for laboratory purposes, but not to do PRF. Recent studies show that these tubes are potentially toxic because of the acute cytotoxic effect they can cause on human cells. My friend, pay attention. As we are reusing the blood from the tubes, we need safe tubes and good quality tubes. Those tubes are only for laboratory purposes, but not to do PRF. Don't play with your patient health. The tubes are under vacuum. This way, don't remove the cap at the beginning of the procedure and don't disconnect the tubes and the tube holder several times, or you can lose the vacuum. The timing of the phlebotomy. Time is the enemy of PRF. If you lose time, you will have less fibrin and less nicer clot. The blood drawing first has to be the fastest possible. See the difference of the clot size between a fast and a slow blood collection. You have to know that with time, the fibrinogen is consumed and thus the clot size decreases. Don't lose time. Once the tubes are filled, we need to immediately launch the centrifugation, and at the end of the cycle, the clot should be quickly removed from the tube. See, the more you wait, the more your fibrinogen will be consumed and your clot size will decrease. See the difference between 10, 30 and 60 minutes. Don't remove the clots more than 15 minutes after the end of the spinning cycle. And the loss of time is the main origin of PRF issues. Now, since 2020, with the pump pad technology, the tolerance is increased. Indeed, with the pump pack, we can lower the temperature of the tube and thus of the blood and slow the clotting. Once your membrane, plugs or sticky bond are prepared, they can be stored inside the PR box and can be maintained and kept at room temperature for up to 4 hours, and it's actually more than you need.